The topic that we'll be discussing today is one on basically wounds. We'll look at what exactly are wounds, what are the various types of wounds, how do you classify the wounds, and more specifically, what exactly is a CDC classification. CDC stands for Center for Disease Control in the United States. And further on, what kind of wound would require treatment and what kind of wound or wounding would require a prophylactic antibiotic. So this will be the scheme of our discussion. Now, when we say wound, what exactly do we understand by wounds? Surgical wounds, or for that matter, any wound, is basically a physical injury to any part of the body. We don't take into consideration about the functional damage that is there. We are talking only about the physical injury that we see. So any physical injury that happens to the human body is something that we classify as wounds. In surgery, when we classify the wounds, there are basically two types. One is a closed wound, other is an open wound. Open wound is the type of wound which we know where bleeding is happening and there is loss of tissue. Whereas closed wound is those type of wound where there is avulsion, there is hematoma. In these kind of wounds, there is structural damage that is there, but most of it is internal and we cannot really see it. But it goes through the whole process of wound healing that we had discussed earlier in one of the classes. Then further on, we can classify the wound as tidy wounds and untidy wounds. Tidy wounds are those which are basically clean-cut wounds, and untidy wounds are those which are contaminated with dirt, like a accident that happens on the road. There will be a lot of contamination of dirt and other things which you find on the road that will be contaminating the wound. Obviously, the untidy wounds, the healing process is a little different from tidy wounds, and tidy wounds heal much faster as compared to untidy wounds. Then the other big classification we have is acute wounds and chronic wounds. Acute wounds are those which happen over a small period of time, and they go through the process of the wound happening and the process of wound healing, and over a period of time the wound heals, and of course the remodeling happens, which takes about 6 months. Whereas in chronic wounds, the various stages of wound healing that are there, the inflammatory stage and the other stages that are there, these stages are actually prolonged very much. So the wound takes a long time to heal, and many a times it requires some amount of surgical intervention from the surgeon side for allowing the wound to heal. So these wounds take a much longer time to heal. They are called chronic wounds. And acute wounds are those which are simple wounds that go through the process of healing and heal off within, let's say, 15 days or maybe a month. Now, open wounds, the various types of open wounds that we commonly encounter are those which are called as incised wounds. Incised wounds are caused by clean, sharp edge objects like knife, blade, etc. I'm sure at some point in time you may have had this kind of incised injury when you're working in the kitchen or you're trying to sharpen a pencil. Lacerated wounds are those wounds which are caused by blunt trauma. Penetrating wounds, a classical example of that would be a stab injury to the abdomen, which happens in drunken brawls. This is something that we keep seeing very often in a casualty setup. Many patients come to the hospital with penetrating injury. Crush injury again is something that is quite synonymous with trauma, and when we say trauma, we are talking mainly about the road traffic accident. Of course, you can have earthquakes, but earthquakes are not something that happens very frequently. Then you also have industrial accidents, and so on and so forth. Puncture wound, by definition, anything that leads to breakage of the skin and entry of a foreign body inside is called basically a puncture wound. So if you say penetrating wound also in a form is punctured wound, but most often punctured wounds are those where the depth is much more or it may be less, and classically it happens usually a needle stick injury is a classical example of a puncture wound. And for a surgeon, while operating many a times we accidentally puncture into our own hands or maybe the assistant's hands while operating, especially when we are using the needle to do a suturing. So these are some of the common types of wounds: incised wound, lacerated wound, penetrating wound, crushed injury or crushed wound, and of course the puncture wound. Now, among the closed wounds, the wounds which you commonly encounter, which we which we term as closed wounds, are number one, contusion. Second thing is the hematoma, and third is abrasions. These are common forms of injury which you usually see in a road traffic accident, or when you are playing and you fall down and you get abrasions. Hematoma is where bleeding happens internally and there is a swelling which is quite obvious. This is just to tell you about tidy and untidy wounds. Tidy wounds, a classical example is an incised wound, whereas for an untidy wound, a class example would be an avulse injury or a crushed injury. Now here what you see is basically a avulsion injury or a degloving type of injury. Here there's a lot of tissue loss, and in the place where the trauma has happened, obviously there's going to be a lot of contamination which is there in this. So in the presence of this contamination, obviously the wound is not going to heal, right? So it needs a thorough cleaning before you can do any suturing of these edges to this and allow it to heal. So basically, in the untidy wound, there's a lot of contamination, and obviously in the tidy wound, there's not much of contamination. The tissues here appear quite healthy. The tissues here obviously appear rather devitalized. Here there is hardly any loss of tissue, but here there is already loss of tissue, and also over a period of time what will happen is some of the areas will lose their vascularity, and definitely you are going to have a lot of loss of tissue. Therefore, the management of an untidy wound is quite difficult and different from a tidy wound. Here the natural process of healing usually takes place, whereas here a lot has to be done by the treating doctor to allow the untidy wound to heal ultimately. Now, this is something that we have discussed earlier, the various factors that affect wound healing. I'll just go through it. Site of wound. In a vascular area, if injury happens, the chances of the wound healing is much better. Structures involved. By this, what we mean is, again, the muscles usually heal very well, the skin heals very well. But if it's involving the tendons and the ligaments, the healing is rather poor. Mechanism of injury. Obviously, as you saw in the earlier slide, a clean incised wound heals much faster. A crush or a avulsion injury. A crush avulsion basically is a degloving type of injury. Both the crush and the degloving injury, they take a much longer time to heal, and many a times they become chronic, but ultimately they heal if proper care is taken. And whether or not contamination is there also affects the healing. If contamination is there, obviously the healing is going to be poor. Loss of tissues, yes, if there's loss of tissue, healing is going to be poor and slower. Then there are other local factors, like the vascular insufficiency. Like for example, if the injury happens to a person who has vascular insufficiency because of peripheral vascular disease, the healing is going to be poor. When the injury or a wound happens in a varicose vein leg, where he is suffering from what we call as venous hypertension, there also the healing is going to be poor. Any part of the body which was exposed to radiation, radiation leads to a lot of damage and fibrosis in that area. And because of fibrosis, the vascularity in that area is poor. So the healing obviously is going to be poor. In those areas which are pressure-bearing areas prevent the natural process of healing, and therefore the healing is retarded. Then you have a whole lot of systemic factors like malnutrition, vitamin or mineral deficiencies, and most important, of course, is the systemic disease of diabetes mellitus. Diabetes mellitus, as we know, affects to a large extent the process of wound healing, including it affects your cell-mediated immunity. And that is the reason why diabetes mellitus is in news so much today in this COVID scenario, because patients who have long-standing diabetes mellitus usually will have some amount of depression of their cell-mediated immunity. Therefore, their ability to fight the virus, the fungi, or the bacteria is definitely compromised. Among the medications, leading is steroids. Steroids actually reduce the amount of healing or the granulation tissue that forms. Therefore, a patient who's on a chronic dose of steroids, such patients, the wound healing is going to be poor. And there are other, just like the steroids, other therapies like chemotherapy, or a patient who's basically an AIDS patient. In these also, because poor granulation tissue is formed, the healing process is rather poor. Smoking is known to affect the quality of collagen. And collagen, as you know, type 3 collagen deposition happens in the process of wound healing. The collagen that is there in smokers, chronic smokers, is a little defective, and therefore the quality of wound ultimately is rather poor. So when you manage an acute wound, the steps you generally go through are: number one, of course, before you start cleaning, you ensure that there is no obvious bleeding. If there's any bleeding, you control that bleeding area by probably applying pressure. Then you clean the wound, explore properly to see what is the extent of damage. Whatever devitalized tissues are there, you basically take them off. Sometimes you have to repair the structures, like supposing a tendon is cut. You can't leave the tendon as it is, a divided state. You need to approximate both the ends. Therefore, you'll repair and you'll suture the tendon. Sometimes, if a blood vessel is cut, you may have to repair the blood vessel to ensure that there is no distal neurovascular deficit. Sometimes replacement of tissues may be required in the form of making a local flap. Sometimes, if the skin cover is too much deficient, you may have to bring some skin cover, like in the form of a skin graft, because ultimately in the process of wound healing, the epithelialization has to happen on the top. And like I told you, most of the epithelialization happens from the surrounding skin. But when the defect is very large, the surrounding skin is not able to cover that. So what happens, instead of a scar, you actually will be having a lot of fibrotic tissue, and that is not good for the wound, and obviously cosmetically it is not very good. So skin cover is something that is very important. Whenever you are closing the skin, just when you have a large defect, if you try to close the skin or approximate the skin with a lot of tension, this tension that is provided to the wound, that itself retards wound healing. So any closure that is done in the wound has to be with appropriate tension, or there should not be too much tension in the wound. Next, we go to a feature which is quite commonly seen in trauma cases. This is called as a compartment syndrome. Now, maybe in orthopedics they'll be discussing about compartment syndrome, but compartment syndrome is an entity which a general surgeon sees, an orthopedic surgeon sees, and almost every surgical department which is there at some point or the other usually may encounter this entity called compartment syndrome. So compartment syndrome, what exactly it is? Compartment syndrome typically occurs in the closed lower limb injuries. Closed lower limb. It's not that you have a cut here. The skin is absolutely okay. That means probably you have a huge hematoma or you have a huge contusion along with probably abrasions on top of it. So this is the kind of scenario when it happens in the lower limb. When we say lower limb is most common, but it can also happen in the upper limb. Now compartment syndrome can also happen in the abdominal cavity, where it is known as abdomen compartment syndrome. Usually, the features which are different in this is because of the intense pressure it causes. What happens is the flow in the vessels, the blood flow, the arterial flow as well as the venous flow is compromised. So, patient usually has, number one, severe pain in the limb, pain on passive movement of the compartment muscles, and definitely he'll be having, most importantly, the pulses will not be felt distally, and also he'll be having some amount of sensory loss. Now the problem is, we don't wait till the pulses disappear, because by the time pulses disappear, it is probably a situation where we may have lost the limb. So we generally assess all these things. Then what we do is, pulses, it's much better to do maybe a color Doppler and see what is exactly the status rather than wait for the physical disappearance of a pulse. A compartment syndrome, if it's not treated at the outset when we have seen it and we wait for the pulse to disappear, if we wait for the pulse to disappear, most likely we may end up losing the limb and the limb might require an amputation. So the compartment pressure, usually if we look at the compartment pressure, there are means and ways by which we can measure the compartment pressure. If the compartment pressure is more than 30 millimeters of mercury, it is a very dangerous situation, because it is the pressure at which, the inflow which is happening at the level of the capillaries, that is retarded. Typical clinical features, of course, we don't really wait for that to happen. Typical features usually will be what I have just described in my earlier slide, one of pain, loss of sensation, and pain on passive movement. These are the typical clinical features. Like I said, we can use a color Doppler, or if we have this compartment monitoring, we look for a pressure of around 30. The moment it reaches around 30, probably we will have to intervene and do something. The reason why we need to do something early is, if you don't, you end up losing the limb. So the technique of fasciotomy usually is a longitudinal incision from the skin, including the deep fascia, that is made. Now, it's important for us to remember that the muscle is covered by the deep fascia, and this deep fascia forms like a compartment in which the muscle is totally encapsulated. So this fascia, the deep fascia, needs to be cut, and the act of cutting the deep fascia is what we call as a fasciotomy. This is usually a longitudinal incision which is put on both sides, the medial aspect and the lateral aspect of the limb, whether it's the upper limb or lower limb, right from the skin up to the deep fascia. So as soon as you do that, the muscle usually bulges out. Lower limb, both the decompression are usually done in, by putting two incisions. This is how it looks. Here incision is being made. Here you can see the skin, you can see the subcutaneous tissue, and just over the muscle is what you see is basically the deep fascia, which is forming a envelope or a compartment of the muscle. Once that is done, the compartmental pressure comes down, and once the compartmental pressure comes down, the distal flow of blood happens, and also the blood returns, and that is how viability is maintained. Now, there's one or two problems of fasciotomy that we need to know. When you do a fasciotomy, the longer you wait before you do a fasciotomy, the more problem you're likely to have. Because as a result of decreased blood flow, what is happening is there is a lot of accumulation of lactic acid because of a shock state that is there. Shock is basically a condition where the perfusion that is coming into that area and bringing oxygen supply is not adequate enough. So what happens is there's a lot of lactic acid that is generated and accumulated in that area. Then from the dead muscles also there's a lot of myoglobin that is released. So what happens is the moment you make this fasciotomy cut, what happens? The pressure gets relieved. So what happens? The blood circulation to this area, and more importantly back from that area, that restarts. When that starts, lot of myoglobin and lactic acid and potassium, etc., they actually come back into the systemic circulation, and this can lead to acid-base derangement. Also there can be electrolyte derangement in terms of hyperkalemia, and this myoglobin this myoglobin itself gets deposited in the glomerular basically in the glomeruli, and that can lead to glomerular damage, and ultimately you end up with the kidney damage. So these are some of the problems. As far as compartment syndrome is concerned, I am sure the orthopedic people will be talking about this in course of the discussion, or maybe when we talk about the abdomen, we'll be talking about it. But it is important for you to know at least something about compartment syndrome, because it is a very, very important topic. This is where probably we can expect a short note. Now, chronic wound, a chronic ulcer unresponsive to dressing and simple treatment. Basically, this is a very simplified description of what exactly a chronic wound is. Obviously, a chronic wound is unresponsive to the routine dressings and simple treatments that we usually institute to most of the ulcers or wounds which heal on their own, and those variety we call as simple injuries. Okay. Many a times, the reason why this so-called chronic wound does not heal is maybe it is a malignant ulcer and we are not aware of it, and we are going on doing the dressing. Maybe it's a decubitus ulcer and we have not checked it. So therefore what happens is, a chronic ulcer which is not healing requires some additional intervention apart from the routine dressing and simple treatments that we institute. Most commonly we try to rule out the possibility of that wound being a malignant ulcer. The common malignant ulcers that we usually encounter is usually a squamous cell carcinoma, and in the face area we encounter another skin tumor which is called as the basal cell carcinoma. We also need to check for possibility of loss of sensation which happens in decubitus ulcer. And another thing that points to the possibility of decubitus ulcer is this ulcer or wound may be in a pressure bearing area. The moment we see a wound in the pressure bearing area, we should always consider the possibility of decubitus ulcer. Now, all decubitus ulcers, not necessarily they'll have loss of sensation, but in some of the decubitus ulcers which happens because of some sort of neural damage into that area, patient can have loss of sensation. A classical example of a decubitus ulcer could also be a diabetes mellitus patient who develops diabetic foot. In an advanced diabetic foot, many a times there will be loss of sensation. So here, it is important for you not only to treat the local wound, but whatever is the primary condition that has led to like loss of sensation or decreased vascularity, these things need to be addressed. Only then we can expect the wound to heal. Now, we just go to leg ulcers because this is one area where you find a lot of ulcers. So in the leg, most commonly you find something called as a venous ulcer. Venous ulcer happens in a condition called as varicose veins, and in varicose veins there is what is called as local venous hypertension in the limb. So here you have very classical ulcers, which I'll be showing in the next picture. Then you also have this arterial disease. So we have this venous ulcer, which you see in venous diseases like varicose vein and venous hypertension. You also have arterial diseases where you have arterial ulcers, and commonest arterial condition is usually atherosclerosis. Then arthritis, trauma, which we have already talked about, chronic infection like tuberculosis and syphilis, and of course, most importantly, the neoplastic. Now, here are the various ulcers. This is mainly in the leg. Here, this ulcer which you see, you know what are the parts of an ulcer. Ulcer has basically, this is what is called as the edge of an ulcer. Okay, the edge of the ulcer can be sharp, sloping, everted, or it could be rolled out. Now, sloping is something that is characterized as the edge that you see in a healing wound. Undermined is something that you see in tuberculosis, whereas everted edges is something that you see in squamous cell carcinoma. Rolled out edges is something that you see in basal cell carcinoma. Okay, so on and so forth. And apart from that edge of the ulcer, you will also have what is called as the floor. Floor is what you see. Okay, so floor is usually you will have granulation tissue, and over that you may have some amount of crusting either because of pus or some exudate coming out, usually serum coming out from that area. And below that, where the floor sits, that is what is called as the base of the ulcer. Then you also have what is called as the margin. Margin is basically the normal skin and the edge. The junction of that is basically called as the margin of the ulcer. So here in arterial diseases, usually the ulcers tend to be nice and punched out. Then what is also important is you will not see very good amount of granulation tissue. The limb itself will appear a little pale, and also the granulation tissue appears little pale. Of course, here I don't find it looking so pale, but usually it is pale. And of course, more importantly, the patient will be having features of arterial disease like atherosclerosis, in which the patient has developed a peripheral vascular disease. Okay. Then you have this venous disease where you have a venous ulcer. Now, this venous ulcer is something that is very important for you. Of all the ulcers that I have shown you, the decubitus and the venous are perhaps the most important. The venous ulcer classically develops because of venous hypertension. The blood is not able to go back properly because there is some problem in the veins of the patient. So this ulcer classically develops just on the near the middle malleolus. This is the medial side and that side is the lateral side. So above the medial malleolus, usually this ulcer will be found. Okay, and one problem is the moment the limb is in a dependent position, the chances of bleeding is very, very high. So whenever bleeding happens, you don't try to press it like it happens in a case of arterial bleed. You just elevate the limb above the level of the heart and the bleeding stops. So this is also a chronic condition and takes a long, long time to heal. Then you go to the tubercular ulcers. So tubercular ulcers generally, on their own, they do not heal, obviously. And there are some features. The most important feature of the tubercular ulcer is there is a lot of undermining of the edges that is there. Okay. And compared to most other ulcers, we find that this margin area. There's the edge, and near the edge you have the margin. That usually has a bluish hue. Why it happens, we do not really know, but that is what is there. Whereas if you go back to the venous ulcer, we find that the venous ulcer, there's a lot of pigmentation that happens in and around that area. And if you enlarge this picture, you'll see small, small veins, which are known as reticular veins. This is very, very classical of venous ulcer. So anyway, the tubercular ulcer is basically a chronic form, and here many a times simple dressing does not help and allow the wound to heal, and ultimately anti-tubercular treatment has to be instituted for the wound to heal. This is a classical example of a decubitus ulcer which is there in the sacral area. This is the left glutea and the right glutea, and between that you have a large ulcer here. So this happens because of, the patient is bedridden and is unable to move. Ideally, you should frequently change his position, which for some reason or the other has not happened, therefore he has developed this ulcer. So here what happens in any pressure bearing area, the healing is very, very poor. And it takes a long time to heal, and many a times it requires for us to excise this area and bring in a flap for it to heal. But most importantly, we have to ensure that we do what is called as pressure offloading, meaning which we do not subject this area to any pressure. This is of course a squamous cell carcinoma. Squamous cell carcinoma, many a times, of course by this stage, I'm sure most of us would realize that something is really wrong. It is not a simple wound that we are dressing. But there have been instances where people have tried, doing dressing for squamous cell carcinoma and, referring to hospital saying that the wound is not healing. And then we do a biopsy and we find it to be a squamous cell carcinoma. So pressure source, just to know a little, the decubitus ulcer or pressure source are the same. They are also known as bed sores. They occur in 5% of all hospitalized patients, but the important group of patients where this happens is those who are paraplegic, elderly, and who are bedridden. Now, this is a very important slide just to show you the areas where it is common. The commonest area of pressure source is the ischium. Then you have the greater trochanter, then the sacral area, the heel, the malleolus, especially in the lateral aspect of the malleolus, and of course it can happen on the medial side, but the lateral aspect is more common. And last but not the least, in the occipital area, also in a patient who is lying supine, you can have these ulcers developing. Most important is ischium is the most important, that you need to remember. Now, decubitus ulcers, there are 4 stages of these decubitus ulcers. In stage 1, what happens is, there's only erythema. There's no loss of any element of the skin. Here you just have erythema without any loss of skin. Usually at this stage, if it is detected and if you take care, the process will not develop further and the wound will heal. But if you don't take care of the stage 1, from erythema, so erythema continues to be there. But what also happens is partial loss of skin. So when we say partial loss of skin, what exactly is lost? What is lost from the skin is the epidermal layer is lost and some part of the dermis. Dermis has papillary and reticular dermis. The upper part, which is the superficial dermis or the papillary dermis, that part is lost. Right? So here you have a small superficial wound. In the third stage, you have a full thickness ulcer. When we say full thickness, we mean full thickness of the skin is lost. So here you have, of course, there may be, here the question of having erythema is not at all there. But compared to the stage 2, what you see is the ulcer here is much deeper and the whole of the skin is gone. And here, this is the subcutaneous layer. So it has gone up to the subcutaneous layer. And if it goes deeper than that, then perhaps it will become the type 4 or the stage 4. So in stage 4, of course, the skin is fully gone. The subcutaneous fat is also gone. It has reached either the muscle area, this is the muscle layer, or it has reached the bone. In some areas, you may not have muscle, and under the subcutaneous area, probably you will be having the bone itself. So, full thickness ulcer which involves either the muscle or the bone, that is called as type 4. So this classification basically tells you that the type 4 basically takes a much longer time for healing to happen, whereas stage 1, the healing is much faster. Stage 2 is basically progression, how long it takes for the wound to heal. Okay, you can I mentioned in my earlier this thing that the occlusive pressure at the level of capillary is around 30 millimeters of mercury. So once the pressure, either the internal pressure as in compartment syndrome or the external pressure as in the case of a decubitus ulcer, reaches around 30 millimeters of mercury, the blood flow usually ceases and there's tissue anoxia with lactate formation. Then there is tissue damage that leads to release of potassium, etc., etc. And of course, myoglobin and hemoglobin is also released into that area. So basically, the problem starts there. So the most important thing that you need to do in a case of a decubitus ulcer is to do what is called as pressure offloading. That means do not subject that area which is already having a stage 1 decubitus ulcer to any further load bearing. So for that we have some, apart from the, basically as far as skin care is concerned, we always ensure that the skin is kept dry. There should not be any moisture in that area. And we, sometimes to offload the pressure in that area, we have special cushions and foams. And we also have what is called as a air mattress in the form of alpha mattresses. These are mattresses, large mattresses, where you have various regions through which air flows very sequentially. Okay, so air will flow from one area and exit through the other. So some areas inflate and deflate sequentially. That is what an air mattress does. And sometimes we also have what we call as bed mattresses to do pressure offloading. I'll not really go into this much, but just suffice to say that pressure offloading has to be done, constant change of position has to happen. And now one new modality of dressing has come, which is known as vacuum assisted closure of the wound. Vacuum assisted closure of the wound, VAC. So again in MCQs, these are the key things that you need to remember, or for that matter when you're writing a short note. If we see the word vacuum assisted closure, maybe we are fooled to believe that you know a lot. So these key things you should write in your short answers, or for that matter long answers. So I'll not really go into how vacuum assisted closure is done. Just to show you, this is how the pressure ulcer was, and after the VAC system has been applied, this is how it looks. So we go to another very important entity in the case of surgical wounds and infections, something called as opportunistic infection. So what exactly is opportunistic infection? In the circumstance of reduced resistance, bacteria that are not normally pathogenic may start to behave as pathogens. This is known as opportunistic infection. So classically, more often than not, we see this opportunistic infection happening in the case of fungi. Okay, you have seen basically fungal as well as bacterial infection, and these opportunistic infections are usually more common in those patients who are immunocompromised. So when they are immunocompromised, what happens is either the resident flora itself becomes pathogenic, or flora from outside, exogenous sources, they enter into the body and they create an infection which usually does not happen that easily. But because of the immunosuppressed state, these patients can manifest infection. Then there is one more entity which is called as the gut failure or bacterial translocation. Now what exactly is bacterial translocation? It's colonization and translocation of bacteria, usually from here, the intestines, into the plasma area. So how it happens? Basically, once you have, we know that the colon especially is full of various types of coliforms. So whenever damage happens, so what is that damage? That damage could be, poor vascularity into this area in a shock state. When a patient is in shock, prolonged shock, this translocation happens, or there could be physical injury into that area. So in that situation, what happens is usually some amount of this bacteria from here goes into the mesenteric nodes, and there's also release of endotoxins from this bacteria. Usually the LPS or lipopolysaccharide is released. So because the release of lipopolysaccharide, the endotoxin, this is something that we talked about, interleukin 1, interleukin 6, tumor necrosis factor. So these are basically pro-inflammatory mediators which come out, and they because of this cytokines, there is further multi-organ dysfunction syndrome or SIRS-like situation that happens. Okay, so and at the same time, what also happens is some bacteria reach this mesenteric nodes, and from here they may also go to the systemic area. So basically, once this bacterial translocation happens, so what happens is the infection or the bacteria which is capable of producing infection is now introduced into the body. Body meaning from the gut, it has now gone into the systemic side. So, I mean, most of these patients either can produce, sepsis itself will be there. Otherwise, because of predominant release only of cytokines, there could be a MODS-like situation or a SIRS-like situation, systemic inflammatory response syndrome. Along with systemic inflammatory response syndrome, if you have the infection, that would be called as sepsis. Okay. So now, what are the factors that will determine whether the wound will actually become infected or not? Because every wound that is there does not necessarily end up in being infected. And we also know that once infection sets in, the healing of the wound takes a much longer time. So number one is the host response, how good your immunity is. Young patients have much better immunity, older patients have poor immunity, those on chronic illness and comorbids have a poor immunity. Then you have the virulence and the inoculum of the infective agent. Sometimes some variety, especially the ones which are hospital-acquired infections, they are very, very virulent, these organisms. And sometimes the amount of dosage that is required. If you have a very small contact, maybe it won't be able to produce that much of an infection because your host response may take care of the inoculum of bacteria or fungi that has gone in. But if the inoculum is high, virulence is high, the chances are that your wound will get infected. Vascularity into that area is something that we have already talked about. The vascularity is good, chances of infection are less, whereas vascularity is poor in the form of ischemia, then chance of infection are much more. Other very important thing, especially when it happens in road traffic accident, there will be a lot of foreign debris that is there within the wound. As long as the foreign debris is there, it will also lead to infection and also retard the process of wound healing. Presence of antibiotics, there is something called as a decisive period. I think in the next slide we'll be talking about it. So basically, in most of this condition, we need to institute antibiotic. Again, the timing of antibiotic is very important. And there is something called a decisive period. It is usually a 4-hour period. Usually within that 4-hour period, if you start the antibiotics, the effect of the antibiotics on the virus, on the bacteria is much better. And before they have mounted a lot of inflammatory response in the body, the antibiotics start acting on the bacteria. And that is what is called as the decisive period. Okay. So now as far as classification of wound is concerned, we have basically 4 classes of wound. The CDC classification of wound. Center for Disease Control, this is in the US. Class 1 is basically a clean wound. In a clean wound, usually this is a wound that happens when we do an elective surgery. When we put an incision, the kind of wound that we get is basically a clean wound. It is not associated with any trauma. No inflammation encountered. There is no break in the technique. The technique meaning the operative technique. There is no spillage of either respiratory fluid, gastrointestinal fluid, or genitourinary tract fluid. So a classical example of a clean wound or a clean surgery would be something like a hernia operation or a MRM, which we do in a case of a breast cancer. So these are clean wounds. These clean wounds, there is no trauma associated with it. Because we are using a scalpel, of course, it does produce a bit of trauma, but it is a very focused area of trauma. There is no inflammation that is encountered because the tissues are not inflamed either, it is normal tissue. And there is no breakage in technique. What do you mean by no breakage in technique? There is no contamination with any extraneous source of infective material. And also, we are not entering into the respiratory tract, not entering into the gastrointestinal tract, and to the genitourinary tract. Okay. Then we go to class 2. Class 2 is basically called as clean contaminated. In clean contaminated, there's non-traumatic wound, okay, with minor breakage in technique. The gastrointestinal tract, respiratory tract, or the genitourinary tracts are entered, enter. That means, let's say in this case, I am doing a gastrectomy. So in gastrectomy, I'll be cutting the stomach. But what I would have done is, before the operation, I would have done what is called as pre-operative preparation. In that, I would have given stomach wash to this patient. So I am entering into the GIT, but there is no significant spillage because care has been taken pre-operatively and also intraoperatively. So the spillage that happens is not significant and it is not that detrimental to the body. Okay, so this is termed as clean contaminated. So any entry into the gastrointestinal tract, respiratory tract or genitourinary tract in a controlled fashion or in a planned fashion would be termed as clean contaminated. Then we go to the next, that is the third variety, which is contaminated. So here, there is major break in the technique. Okay, gross spillage from the gastrointestinal tract, biliary tract. I mean, gastrointestinal tract also we include the biliary tract, gastrointestinal tract, genitourinary tract, or the respiratory tract. So this is important. Penetrating trauma, which is usually less than 4 hours, or any chronic wound, is also classified as class 3 because there is a lot of contamination in the wound that is already there. Now, when we talk about this CDC classification of wound, most of this wound is in terms of the surgical operation that we do and the kind of field in which we operate and the type of contamination that may or may not happen. So based on that, we have clean, contaminated, and the next category is the dirty or infected wound. Here, traumatic wound from dirty source, already a dirty wound. Traumatic wound with delayed treatment. There's a wound which has not been treated for a long time and obviously it is infected. So that would again classify as dirty infected. In the surgical parlance, when we operate a patient who already has fecal peritonitis, or there is foreign body, or there is purulent infection. Purulent infection means inflammation from where pus is coming out. That is basically synonymous with infection. Or the patient has a hollow viscous perforation, like a perforation in the stomach, perforation in the small bowel, perforation in the duodenum, perforation in the colon. These perforated viscous are also examples of dirty wound. So the main thing about these classification of different varieties of surgical wound is, as the class increases, the resident bacteria that is available or that is already there in that area is very, very high, and therefore the chances of infection is very, very high, and accordingly we decide whether or not to institute antibiotics. So this is a slide which is the result of what I have shown you in the earlier 4 slides. You have class 1, which is called the clean, class 2, clean contaminated, this is the class 3 or contaminated, and this is the dirty. So here you see what is the risk of infection with antibiotic and without antibiotic. Without antibiotic, in the clean variety, the risk of infection is just around 1 to 2%. When you give antibiotic, it definitely reduces it below 2%, but basically there's not much difference. So in clean contaminated wound, like in a hernia operation or a breast operation, perhaps there is no need to give any prophylactic antibiotic, as long as your skin preparation and other things are usually good. But usually, most surgeons, what they do is, they usually will end up giving 1 dose of antibiotics or maybe even more than that. But as per the recommendation, usually no antibiotic is required. However, just to be on the safe side, 1 or 2 doses of antibiotics are usually given. Now you come to the clean contaminated. Without antibiotic, see the infection rate, 20 to 30, which is very, very high. But once you give antibiotic, it comes down to less than 10%. So here definitely there is a role for prophylactic antibiotic. You go to the class 3, up to 60%, that is the incidence of wound infection. And that is reduced down to 15 to 20% if antibiotics are used. So definitely there is a role for antibiotics here. Here obviously, when we talk about dirty infected wound, infection is very, very high. With antibiotics, we tend to bring it down to around 40. But if you, without antibiotics this much, with antibiotics this much. So without antibiotic, if the rate is so much and the difference is around 20%, obviously there is a role for antibiotic right from the beginning. And here when we give it, we don't give it in a prophylactic mode, but we give it in what is called as a therapeutic mode. So clean, perhaps no role, but just to be on the safe side, we do give. Clean contaminated, yes, there's role for prophylactic antibiotic. Clean contaminated, yes, there's role for prophylactic antibiotic. But in the dirty wound, it is not prophylactic antibiotic, but we give antibiotic in a therapeutic mode. So just a few words about the prophylactic antibiotic. The whole aim of giving antibacterial prophylaxis is to reduce the incidence of post-operative wound infections. This is the decisive period that I was talking to you about. Okay, what is exactly the decisive period? The inflammatory, humoral, and cellular defenses take up to 4 hours to be mobilized. Okay, they take about 4 hours to be mobilized. This is called the decisive period. It is the time when the invading bacteria may become established in the tissue. That means within 4 hours, while your inflammatory, humoral, and cellular mechanism is kind of gearing itself to take care of the bacteria, the body is practically defenseless, so to say. So if you have a very vigorous type of infection with a very potent organism, within this 4 hours it can do a lot of irreversible damage to the tissues. So during this 4-hour period, or within this 4-hour period, if you are able to institute antibiotics, that would be very, very helpful. And this is where the role of prophylactic antibiotic comes. So I'll be talking also to you about the timing of prophylactic antibiotic, how it is to be given. We'll come to that. So in surgical practice, where do we give prophylactic antibiotics? We do it in procedures which are associated with a high risk of infection. Infection is not there, but having done that operation, chance of infection are very, very high. So there we start in a prophylactic mode. It involves implantation of any prosthetic material like a mesh graft or maybe an orthopedic implant we are putting. So in these areas, once you have put this prosthetic material, if infection happens, the consequences of infection is very, very high. Sometimes the prosthetics cost a few lakh rupees to a few thousand rupees. So apart from the loss, apart from the fact that infection is there, you actually end up, you may have to take out this prosthetic material because it will be acting as a foreign body now. So wherever the consequences of infection are very, very serious, we probably end up giving prophylactic antibiotic. Now, how do we choose an appropriate antibiotic to use as a prophylactic agent? Now, we need to see which antibiotic is effective against the pathogens which are most likely to cause the infection. Like, for example, when we are doing a superficial operation in the skin, the most likely pathogens that come into the wound are those from the skin. Okay, so usually there is streptococcus and staphylococcus that need to be taken care. Okay. Similarly, when we are doing an abdominal operation and we are opening into the abdominal cavity and then into the GIT, from the GIT you can have a lot of enterococci and other things coming, including bacteroids. So we need to cover those agents. That is how we choose an antibiotic. Then we also need to have, apart from the fact that they should take care of the pathogens which are most likely to cause the infection in that area, we also need to ensure that the antibiotic that we are giving has a good tissue penetration. Sometimes also, through what route it may be given, those things are also important. We prefer to give antibiotics which can be given, which are versatile, can be given both through the oral route as well as IV route. But as long as it can be given through the IV route, we are happy about it because many a times sick patients are not in a position to take antibiotics orally. Then we ensure that the therapeutic concentrations in blood and tissues at the time of incision. At the time of incision, when the incision is put, the maximum concentration of antibiotic should be there so that it satisfies the so-called decisive period. Decisive period was 4 hours, right? So by the time an incision is put, we should ensure that peak concentrations of the antibiotics are already there in the body. So this is just what I told you, the common organisms that we encounter in different areas. So here, the prophylactic, just you need not remember everything, but maybe just to give you a basic idea. Whenever we are doing vascular surgeries, we usually prefer something like 3 doses of flucloxacillin, and along with that probably we add one gentamicin and vancomycin. Here basically we are mainly covering the gram positive by giving, this is of course a broad spectrum antibiotic, and along with that we are giving gentamicin, vancomycin. Vancomycin and rifampicin actually are very good for staphylococci. Okay, so basically we are targeting gram positive whenever doing vascular surgeries. In orthopedic surgery, usually 1 to 3 doses of a broad spectrum, usually cephalosporin, either a second generation or a third generation cephalosporin is used. And there is also something called a gentamicin bead. I think when you go to orthopedics, you can ask them what exactly is gentamicin beads. When we are doing esophageal or gastric surgeries, we prefer to give 1 to 3 doses of second generation cephalosporin. But what we also do is, because we have to deal with bacteroids which are there in the GIT, we also add, and these are anaerobic organisms. To combat the anaerobes, we usually almost always add metronidazole. Sometimes we start with cephalosporin. Once we enter, we find that there's a lot of spillage that has happened. That means probably the problem of bacteroids is going and anaerobes is going to be quite a problem later on. So what we do is we add metronidazole. But mind you, since we have given cephalosporin early, cephalosporin has attained adequate levels. But usually once spillage happens and we give metronidazole straight away, metronidazole reaches its levels well within 4 hours, which is the decisive period. So no issues on that. Biliary surgery, usually we use first or second generation cephalosporin. Small bowel, again cephalosporin. So when you look at the whole thing, you will realize that cephalosporins, the first, usually mostly, just remember the second generation cephalosporins. Second generation cephalosporins are preferred by orthopedics, by GI surgeons, biliary surgeons, of course GI surgeons again GI surgeons here. Now the only thing that is different in GIT is, apart from the cephalosporin that we use, we also add metronidazole. And the reason why we add metronidazole is because of the bacteroids. The route of administration is almost always intravenous. Now, this is again a very important slide. What exactly should be the timing of your prophylactic antibiotics? Usually, we administer this antibiotic within 30 minutes or just before 30 minutes of starting the surgery. Okay, everything has been prepared, but before we put the incision, 30 minutes before putting the incision, that is the time when we like to give the antibiotic, so that in the next half an hour, by the time we actually put the incision, peak levels would have reached. And that is usually how to know which is 30 minutes. When we are subjecting the patient to anesthesia during the time of induction, during the time when anesthetic drugs are given. After that is done and after intubation and all are done, just round about that time, the antibiotics are given through the IV route. Usually, we don't give it more than 24 hours, but this is not a hard and fast rule. It can be given for longer period than that. Many a times, if it's a long surgery, what happens is, if the duration of the surgery exceeds 2 times the half-life of the antibiotic that we are giving, we need to re-administer another dose. And this is, I think, my last slide. This is cefazolin, the second generation. Again here, the second generation cefotitan. Cefazolin is by far the most common antibiotic. Cefotitan is little less frequently used. That apart, we have vancomycin, cefoxitin, aminoglycosides, metronidazole again, which I told you is used a lot. Sometimes instead of metronidazole, we also have the option of using clindamycin and lincomycin. But these are very active against anaerobes. But amongst them, the most commonly used anti-anaerobic agent is metronidazole, next is clindamycin, and third is lincomycin, which is not so commonly available. Okay. So this is how, so basically the half-life of cefazolin is 1.8. That means if you're having 1.8 into 2, that is 3.6. If your surgery is longer than 4 hours, then probably you need to repeat the dose of cefazolin. That is what is important. So that concludes my talk on CDC classification of surgical wounds, and basically an introduction to what exactly wounds are and the types of wounds, and how various factors affect wound healing, and what factors decide whether a wound will get infected or not, and how exactly you should time your prophylactic antibiotic.